Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why. Good evening and welcome to Pause for the Truth. I am your co host, Jocelyn Turner. Such a wonderful evening here in Northeast Florida. I'm in a different space, so if I have some technical issues, I just want to put it out there first that I apologize for that, but my co host will keep the conversation going. How are you doing this evening, Dr. Kane?
I'm doing absolutely well. I'm feeling the those patients that call me out of my name that say, "Hey, Dr. Rogers." I'm feeling like Mr. Rogers in his neighborhood. Such a great, such a great day. I mean, it was just nice today. I can't
Yeah.
complain. I mean, it might have a little bit of heat to it, but hey, compared to what it gonna get, dog days of summer, this was a good day.
Yeah, I agree, Dr. Kane, but I can tell you the weather forecast is triple digits.
Oof,
So we definitely
oof.
need to continue the conversation about urban heat
Well,
and
the heat will kill you
climate.
first.
Right, exactly. So along that line, Dr. Kane, we have an exciting show and a very important show tonight as we talk about strokes, understanding strokes, how to prevent them, treat them, and recovery from strokes because there are a lot of people, unfortunately. I was talking to Dr. Sanders before the podcast started about being here in the South. We have a bad reputation for being a good place for cardiologists and nephrologists and other folks who are trying to respond to our unhealthy ways. So we are delighted to have Dr. Trevor Green join us again. He was on before. Dr. Green, you're muted, but how are you doing this evening? You're still muted, Dr. Green.
There
I
Go
you
ahead.
got
go.
you. I'm up now.
There you
I'm
go.
doing fine. Thank you. Thanks for having me again. Appreciate
Oh,
it.
absolutely. Absolutely. We learned a lot from you last time and so delighted that you are joining us. And along with Dr. Green is Dr. Kalina Sanders. Hopefully, I didn't botch your name up. How are you
Oh,
doing, Dr. Sanders?
oh, that was perfect, Jocelyn. I am doing great. Thank you for the opportunity to come and share information with the masses regarding stroke care and prevention. I'm excited about our conversation tonight.
And welcome to our podcast for the first time. And if Dr. Kane has not told you, or our behind the scenes guy Tyrone didn't tell you, once you come on, you'll be back. So let me just go ahead and tell you that right off the top, so that you'll know. We're going to tell you at the end. We got to continue the discussion. So thank you both. You know, doctors, it seems that when people have a stroke, their life seems to come to an abrupt stop, right? And everybody around them rallies around that person. Dr. Green, let me start with you. What is going on when someone has a stroke? What exactly is happening with their bodies?
Well, the most direct thing is a lack of blood supply to the brain. And Dr. Sanders might be able to speak more specifically about this from a neurological standpoint. But from the standpoint of a cardiologist, the one thing that we worry about is that very common condition called atrial fibrillation, leading to clots coming from the heart going up to the brain. Those little clots get into the blood vessels, the smaller blood vessels of the brain, and they block the flow. And when that happens, patients get a stroke. Now, depending on what part and what blood pressure and what vessel is involved, will determine what it will look like and how the patient will present. But that fundamental thing from a cardiologist standpoint is that small blood clot leaving the heart and heading up to the arteries in the brain.
Oops, thank you, Dr. Green. Dr. Sanders, is there anything you'd like to add?
Oh, definitely. So what Dr. Green was talking about is really one type of stroke. We really think though that there are really three different types of stroke. So the type of stroke that Dr. Green was just talking about is what we would call an embolic stroke, where the clot goes from the heart to the to the brain. But the other two types of strokes are also very common, and maybe more common is one that you can have a blockage in a blood vessel in the brain, just like you could in the blood vessels in the heart. And that blood vessel can become so blocked that it prevents blood flow. But I think another much more potentially devastating type of stroke is a bleeding type of stroke, particularly in people who have uncontrolled high blood pressure, where that blood vessel is not blocked, there's not loss of blood flow, but it actually bursts or it explodes and the blood leaks into the brain and can cause very similar symptoms, if not worse, than the other two types of strokes.
Do people experience any type of symptoms to let them know? I know you mentioned, Dr. Sanders, that oftentimes people have uncontrolled blood pressure, but for those persons who have high blood pressure and take their medications and think they're managing it okay, could they potentially be having any symptoms to indicate that something dangerous is about to happen?
I think, Dr. Green, you probably say this a lot to your patients as well, but I tell mine that hypertension or high blood pressure is a silent killer, because oftentimes you can't feel anything until you've had the heart attack, until you've had the stroke. There are some patients, though, that if their blood pressure is really high, can feel like having headaches or changes in their vision, but that's not always the case until they've developed the chest pain or the stroke symptoms.
Yeah, I remember when I was a younger person, my grandmother, I don't know if she ever, when you're young, you just know grandma is sick.
Mm-hmm.
But I was told later on down the line that she actually had a stroke. I just remembered that once she had whatever was going on, she was that way until to the end of her life, right? And so, why is it that people have such a hard time managing their blood pressure? It seems, just, I don't know, just okay, you eat a low fat diet, you exercise, you manage your stress. Why do you think it's so difficult for them to manage their blood pressures? Don't everybody answer at once.
Well, I can, since I'm on the front line, I'll start.
All right.
I'll start and Dr. Green can subsequently come behind me. Because, as they say, they don't feel anything, they tend to not take it seriously. I can plead and I can do everything I need to do unless something else come along to have them take it seriously. It's like, I don't really need all that medicine. I'll just take this medicine today and that medicine tomorrow, and I'm still taking the medicine, so I'm good. Not admitting or not recognizing that you may need all those medications to get your blood pressure under control. They don't monitor the blood pressure. I'm being primary care, I'm on the front line. So a lot of them do not monitor their blood pressure. We tend to eat and do the things that are directly contradictory to what we asking them to do, because it's a habit and whatever it may be. I'm not going to say, what was that you said Dr. Green was eating earlier?
Dr. Green said, don't throw him under the bus. I'll say I eat oxtails.
Yeah, I'm not going to throw an oxtail or anything else along that line. I'm not going to throw that in, but we tend to see patients just don't tend to comply as well as they should. Now, sometimes it's because of, and I'm not trying to demean anybody, sometimes it's because of ignorance. They just don't understand the whole process.
Yeah.
And other times it's because of they may not have the right, may not have medications,
Mm-hmm.
Can't afford the medications. You know, I have sales rep come in and say, hey, look, it's only going to cost them $25 a month. That's real cheap. But when they got 4, 5, 8 different medications,
Right.
you know, and if all of them cost $25 a month, you quickly get to $200 a month, which many of our Medicare friends, that may be a third to a fourth of what they actually get in for Medicare. So a third of much of their monies are going in to paying for medicine. So that's a multitude of reasons, but primarily it's either because of willful neglect of one's self. I'm not even talking about someone taking care of them.
Yeah.
But willful neglect of oneself by way, whether it's because they ignore, they don't want to go and look at their blood pressures or check their blood pressures, or they ignore the advice that my two guests give them, and include myself. They ignore the advice that we give them because they've never had anything happen to them. And especially with men, we get that sense of omnipotence that we've been fine all our lives and it's not an issue. So a lot of times this is because of ignorance of not knowing your numbers and or understanding what blood pressure is all about. In a nutshell.
Dr. Green, you look like you wanted to add something?
Yeah, to follow on from what Dr. Keynes is saying, by the time Dr. Keynes is beating upon the patients and they get to me because he's referring them to me, when they do get to me, the blood pressures are nice and fine. One of the challenges that I have, especially with my own mother and your grandmother, is that once you won the battle, you ran the race, you got the blood pressure under control, and then mom will say to you, well, I don't need to take these blood pressures anymore. My blood pressure is fine. What was the problem, doc? and that's a challenge. I had it with my own mom, who lived to be well into her 90s. So we have to persuade the patients that despite the fact that the blood pressure is now, or in spite of the fact that the blood pressure is now fine, that you need to continue to take your blood pressure medicines religiously. And following up your own blood pressure is also very important. I encourage my patients to do their blood pressures at home, because the blood pressure that you have in the office when you're rushing to get there, the MA at the front, not nice to you, you put you in a room and Dr. Green is running late because he has a lot of patients. You get impatient, and by the time you get that blood pressure, it is off the wall. So home. Ambulatory blood pressures, and that is actually becoming now a whole cottage industry out there. I have a lot of guys coming into the office wanting to set up these systems, and they will all work. But the fundamental thing is that we try to encourage the patients to own their blood pressure, and the more they can own their blood pressure, the better the outcomes are going to be.
But I'd like to jump in and add, and I think Dr. Keynes, you mentioned, there's the willfulness and the adherence to our treatment plans. And I think that there are things that may be out of control, out of our personal control, but we can't deny that there is healthcare disparities, there's social determinants of health. And even if a person wants to do better by themselves, they may not have access to the appropriate resources to do that. We hear about food deserts and having dollar stores on every corner, but no grocery stores with fresh fruits and vegetables, access to gyms and ways to get physical exercises are not in the communities that struggle the most. And so I think that when we talk about the cause for different things, we can talk about the physical aspects, the biology of the disease, we can talk about the individual person, but we also have to think about it in the context of where they live, their socioeconomic status, and having the available resources. I would love to have my patients to take their blood pressure, but just as you mentioned, Dr. Keynes, they have $200 worth of prescriptions. Do they have the money to buy and maintain a blood pressure cuff? And so those are the things that we have to start talking about and addressing, so that when we tell our patients, this is what you need to do, they are equipped with what they need to do it.
Yeah, I just had a novel idea. When we talk about what to give grandma and granddaddy or uncle or parent for Christmas, how about giving them a blood pressure monitor and one with that's dually operated in terms of battery backup as well as powered by electricity. But we have a comment from one of our viewers. Good friend of mine had a stroke 2 weeks ago and had his first heart attack in 2012, and he's 63 now. He's in sales and decided to go back to work recently. I told him to stop working. Am I wrong?
Let me answer that. No, you're not wrong, but it's a little bit more complex. If the person is going back to work at a job that they like, a job that they enjoy, a job that does not cause them any stress, like my job and Dr. King's job. We love what we do. we wouldn't think about doing anything else, right, Dr. Sanders?
That's all we think about is work.
Work. Yeah. So if the whole thing is karma, if staying home is going to be a stress to that person, they don't exercise, they get up late, you don't have a list of life, you don't have anything to. So retirement is not as easy and not as carefree as you might think it is. In fact, there's a really good study out there with letter carriers. We used to call them mailmen, but you got to be careful now. Letter carriers, and they're very active. They walk. Do you know that within 2 years of retirement, 50% of letter carriers succumb to a major cardiovascular event or even death? And the issue there is exercise. So unless you're going back to a sedentary job, but more importantly, if you're going back to a job that you enjoy, I would encourage that person to get out of the house, have a purpose. When you wake up in the morning, you have something to do. You're vested. That is a more that comfort affords a much better outcome. Now, of course, if you're going back to a job that you're stressed and you're upset with your boss and you need to change your environment, that's a different thing. One other very interesting point too is if you're going back to that job and it is a night job as opposed to a day job. I have been fighting to get some of my nighttime employees, the nurses who go to work at night, the policeman who does the night shift, the fireman, the EMT, those are the ones, my special ones that I see. I try to get them when they're at the end of the line to try to switch over to their regular night and day, morning, evening job, night time. And then remember, of course, to the sleep pattern. Once you disturb your sleep pattern, hypertension becomes an issue. Managing it becomes an issue. So it's a very complex answer. Nice question, but it's a very deep question. We really appreciate the fact that that person actually raised that point.
One thing that we haven't, thank you, Dr. Green. One thing we haven't talked about is what are things that people can do to lower their risk of having, say, a heart attack or stroke? Are there lifestyle changes they can make? One thing we cannot do is we can't change who our parents are. That might predispose us already. And we can't change our race. But what else can people do that may increase their risk of developing or lower their risk of having a heart attack or stroke?
Let me say one thing real quick, just elaborate on something that Dr. Green said. These the letter carriers, postmen, mailmen, whatever you want to call them. They are like what he said. They're doing a lot of exercise. They burn a lot of calories. They're staying active. Cardiovascular wise, they're keeping their system up to speed. I liken that what he said. I liken that with what we found out about former NFL and NBA players. You look at a Charles Barkley, you look at a Shaquille O'Neal, and they kind of primary example. These guys eat. They do a lot of running up and down the court, a lot of running up and down the football field, and then they eat huge amount of calories to support their abilities to be able to do that. Then all of a sudden they retire one day. Do you think their eating habits changed? No, it did not. Which is a lot of times what happens with some of the people, lay people, not the those great players or anybody, but other people in the workforce like ourselves that are so busy doing a lot of things, and burning up calories because of what we do, but then we stop doing what we have been doing for 40 years, 45 years, okay, and go home and sit and become sedentary. So what he was saying in terms of the listeners, our listeners' comment is that, you know, if you modify your lifestyle, you need to modify it on all ends, not just it got modified that you no longer go to work, but your diet needs to change, you know, your exercise level. Sometimes, depending if it's a sport figure, I hope it remains the same. But if they're not sports figures doing that kind of stuff, then people like me who don't get a chance to exercise a lot, then I need to up my game once I start my retirement. I'm sorry to interrupt that, but I had to put that in.
Thank you, Dr. Kane. And just Dr. Sanders, real quick, Dr. Kane, and Dr. Green, when my dad retired as a letter carrier, I actually got him to walking. He was a letter carrier for over 30 years. And I immediately started saying, okay, we going to the track when I get off work. And we literally started, unfortunately, he succumbed to lung cancer. Go ahead, Dr. Sanders.
No, I was just going to hop in and add, I think we talked a lot about high blood pressure, diet, lack of exercise, but there are other vascular risk factors for stroke. Smoking is one of them, a huge risk factor. Diabetes, so controlling that as well as other cardiovascular and heart disease, and Dr. Green can throw in onto that. But I would love to echo what Dr. Kane said, is that you really have to change your whole lifestyle in order to help reduce the risk for stroke. It's unfortunate that once a person has a stroke, they're at higher risk for having a second stroke. And so those same vascular risk factors that we talk about to prevent the second stroke can help prevent the first stroke.
Dr. Green, since you're a cardiologist, a lot of times I do steal your thunder in terms of when I talk to patients about having a stroke. You know, when I talk to patients about having a stroke, I steal the thunder part of major risk factors for having a heart attack. Same major risk factors for having a stroke. Okay, a brain attack. I try to get patients to understand even better. You know, those 5 major risk factors: high blood pressure, high cholesterol, diabetes, family history, which you can't change. Family history of having a stroke or heart attack before the age 60, 65. And then, of course, what I missed, smoking
and cholesterol.
And cholesterol. Yeah, I thought that. But yeah, those are. I just wanted to throw that in. That, you know, if you're worried about having a heart attack, you need to be worried about having a stroke as well.
I say the exact same thing. I steal that from you. I say brain health is heart health. Everything you do for your heart, you do for your brain.
For your brain, absolutely.
And by the way, forgive me, I didn't give you an opportunity to tell our guests a little bit about yourselves. Like, what's your specialty? Slap on the hand, shame on me. So before we go to our history maker moment, I'm going to start with you, Dr. Sanders. Tell our guests a little bit about what's your specialty and why did we invite you here to join this conversation tonight?
Well, I'm Dr. Kalina Sanders. I'm a board certified neurologist with Baptist Health. I'm out at the beach. I treat all neurological conditions, including people who have had strokes, migraines, multiple sclerosis, and seizures. I've been in practice for 12 years now. 14 years now. I'm getting a little bit older. And I love educating. And so I think that was the main reason for the invite, is that my excitement and enthusiasm about making sure that our community specifically is equipped with the knowledge that they need to go out and be healthy.
Thank you, Dr. Sanders. And Dr. Green, tell our audience a little bit about you, even though I think I may have said it.
Yeah, well, I practice internal medicine, I practice cardiology, and I practice electrophysiology, all board certified. But I like to think of myself as a internal medicine specialist who enjoys cardiology, who specializes in electrophysiology. Very important because we're training a lot of electrophysiologists now. I'm a little disappointed about how we're doing it because they just want to be technicians and do all the fancy stuff, but not want to sit down and talk to patients about the little subtleties that we're describing here. And I think I brought this up at the Heart Rhythm Society meeting in a year ago in New Orleans, and it got a pretty interesting round of applause. So, but anyway, so that is what I do, and I get a lot of input from Dr. Kane, who sends me a lot of interesting patients and keep me on my toes. But
although that may be good, Dr. Green, that's pretty bad that Dr. Kane has a plethora of patients who need your services.
Just remind everybody, I'm in the hood. I have, you know, I chose to be in the hood. I chose not to go anywhere else because that's where I grew up at. That's why I understand people best. I can understand anybody, but I mean, they're me. They're my family. You know, they look like me. They look like my family, and sometimes I act like my family. But again,
but on that note, though, doctors, and this is to all of you, are African Americans more likely to have a stroke than other populations? If so, why?
Yeah, I'll jump in. Yes. So there is some data or statistics about this that African American men are 70%, twice as likely to have a stroke compared to Caucasian males. And they are 70% more likely to die from a stroke. And that's scary. And I think it's because of all of the things we just talked about, including the vascular risk factors, the social determinants of health, and then not knowing what the signs and symptoms of a stroke are to go and seek the care that they need.
I think also of it may be, I mean, and Dr. Sanders, you alluded to this earlier. I mean, we can't exclude racism. You may not have said racism, I'm going to say it, but we can't exclude racism and neglect of communities from being part of that. We also look at the epigenetics, especially as it relates to Black women. With the studies that have been out there, how they are more likely to suffer the bad consequences of whatever illness that they have as a result of downstream, the downstream effect of racism, you know, epigenetics and yada, yada, yada.
So we're going to pause a moment because I have a ton of more questions for you, and then we'll allow our guests to also, our viewers also to prepare their questions. But at 7 o'clock, midway during the show, we like to feature a history maker. And this is the opportunity that our behind the scenes guy does his homework and will surprise us with our weekly history maker. So Tyrone, take it away. Doctors, don't go anywhere. Get a swig of water or something, and we'll be right back.
Dr. Nathan Francis Mossell was a visionary. He was a pioneer. He was a champion for his people. Born in 1853, he rose above the constraints of a segregated society. He became one of the first African-American doctors to graduate from the University of Pennsylvania's medical school. This was a time when racism was rampant, yet Dr. Mossell dared to dream of a better future. He envisioned a world where healthcare was a right, not a privilege. His life and work were a testament to the power of perseverance. He was a beacon of hope for the African-American community. Despite facing prejudice and discrimination, Dr. Mossell excelled in his field. He became a renowned physician. He was respected for his expertise and compassion. But Dr. Mossell's vision extended beyond his own practice. He understood the systemic barriers that prevented African Americans from accessing quality health care. He knew that the color of their skin should not dictate the quality of their care. This fueled his desire to create a hospital where all, regardless of race, would be treated with dignity and respect. In 1896, Dr. Mossell's vision became a reality. He founded the Frederick Douglass Memorial Hospital and Training School for Nurses in Philadelphia. This was not just a hospital. It was a symbol of hope, It was a declaration that Black lives mattered. The hospital provided much-needed medical care to the African American community. It also served as a training ground for Black doctors and nurses. This was crucial at a time when opportunities for Black medical professionals were scarce. Dr. Mosel's efforts were met with resistance. Racism was deeply ingrained in society. He faced opposition from those who believed that Black people did not deserve equal access to health care. But Dr. Mosel refused to be deterred. He understood that the fight for equality is rarely easy. He pressed on, driven by his unwavering commitment to justice and equality. His story is a testament to the power of one person to make a difference. The Frederick Douglass Memorial Hospital, named after the famed abolitionist, was more than just bricks and mortar. It was a beacon of hope in a segregated city. The hospital provided a safe haven for Black patients. They could receive treatment without fear of discrimination. It was a place where their dignity was respected. The hospital quickly became a cornerstone of the community. The hospital's impact extended far beyond its walls. It became a symbol of Black empowerment. It showed the world that Black excellence could thrive even in the face of adversity. The hospital's success was a testament to the power of community. People came together to support Dr. Mosel's vision. They donated their time, money, and resources to ensure its success. Dr. Mosel understood that healthcare was about more than just treating illnesses. It was about empowering individuals and uplifting communities. He believed that everyone deserved access to quality medical care. He saw healthcare as a fundamental human right. This belief fueled his passion and drove him to overcome countless obstacles. The Frederick Douglass Memorial Hospital was a training ground for a new generation of Black medical professionals. It provided opportunities that were largely unavailable elsewhere. Black doctors and nurses could hone their skills in an environment that valued their contributions. The hospital played a vital role in diversifying the medical field. This, in turn, led to improved healthcare outcomes for the Black community. Dr. Mosel's legacy extends far beyond the walls of the hospital he built. He left an indelible mark on the medical profession in the fight for civil rights. His unwavering commitment to justice and equality continues to inspire generations. He showed the world that Black excellence knows no bounds. Dr. Mosel's story is a powerful reminder that progress is possible. Even in the face of seemingly insurmountable obstacles, change can happen. His life is a testament to the power of perseverance and the importance of fighting for what is right. His legacy continues to inspire activists, medical professionals, and everyday citizens alike. The struggle for health equity continues today. Dr. Mosel's work serves as a reminder that the fight is far from over. We must continue to dismantle systemic barriers that prevent marginalized communities from accessing quality health care. We must honor his legacy by advocating for policies that promote health equity. Dr. Nathan Francis Mosel was a visionary leader. He was a pioneer in medicine and a champion for civil rights. His life and work have left an enduring legacy. They continue to inspire hope and progress towards a more equitable future. His story is a testament to the power of one person to make a difference in the world. Let us honor his legacy by continuing the fight for healthcare justice for all.
Wow.
Healthcare justice. You know, that's one of the primary things we go after on this show. Healthcare justice.
Yeah, absolutely. That was awesome. I want to talk before we continue, start out the conversation about what are some signs or symptoms that people should look for to determine whether or not their loved one is in fact having a stroke, and what should they do?
So if a person that you are around, or if you experience it yourself, you want to look for things like weakness. Oftentimes that's a facial droop or facial weakness, or the inability to move one side of their body. If they have slurred speech, if they have vision changes, particularly if they describe like a shade coming down over their vision, that may be signs and symptoms. And then lastly, if they are off balance or unable to walk, that could be a stroke as well. And if they experience it, or if they see someone around them that is experiencing it, first thing to do is to call 911. We have a mantra that says time is brain. So the faster they can be evaluated, the more likely we can help to preserve as much brain function as possible.
and not drive them to the hospital. Call 911. People tend to want to do that or either go and lay down, I'll feel better.
Mhm.
Right. And it's like, no, that's not, some things that may work. If you have a headache, maybe a normal, just a regular headache, but no, thank you so much for saying call 911. Dr. Green, did you want to add something? Otherwise, I want to go ahead and there was a question. Tyrone, can you put that question back up? I want to ask the doctors that.
And I just want to say that fee for some people worry about that fee for the EMTs coming. Okay, I mean, you'll lose that in terms of productivity within the first day of that stroke causing the maximal effect on you. So don't worry about that cost. They can't get blood from a turnip anyway. So just go ahead and call 911.
That's what my daddy said. He went to his grave owing for EMT visits. But anyway, I digress. So somebody asked the question, can you explain the correlation between high blood pressure and kidney failure?
Now, Dr. Green, I know that would be one of those things I would ask your wife, the nephrologist. However, if we're going to put it to you two guys, I mean, I can say something, but I'm going to leave it up to you, Dr. Green.
Oh, yes. There's a direct correlation between high blood pressure and kidney disease. And I say kidney disease because it is a progression from the time you start having high blood pressure. One of the things that we always want to guard against and want to preserve is the integrity and the quality of the kidneys. And so a lot of our focus, although it is all very silent, is to try to prevent renal failure. Because the one thing we don't want to do, and the thing that bothers us the most, is winding up on dialysis. And that is a place that is very, very uncomfortable. So there is a direct correlation. And when I want to fear my incalcitrant patients, the ones who would not comply, I always invoke the fact that you do not want to be in the dialysis unit 3 times a week, Monday, Wednesday, and Friday for 4 hours. Take your blood pressure medicines.
Not even one time a week.
Not even one time a week.
And don't be annoyed by the diuretics, even though they could be a pain in the you know what. But I still say that the little slight inconvenience from that is definitely better than you ended up with a heart attack or stroke. Tell me about, are there any new advances when it comes to treating people who've had a heart attack and or a stroke nowadays? And, have you seen the evolution of medicine changing, that it's better now to treat someone and the likelihood that they're rehabbing maybe afterwards, or their life after a stroke is not as bad as it used to be? Or is that 2 different things?
So specifically for a stroke, I think there's kind of 2 phases of care. So the first phase of care is that acute setting. So I mentioned before, time is brain. And so the longer you go not getting blood flow to a particular area of the brain, the more likely it is to die and have less likelihood of recovery. But we have had an advancement over the years with treating strokes acutely. And if you call 911 and you make it to the emergency room within a specific amount of time, we usually say within 3 hours of your symptom onset, sometimes it can go out to 4.5 hours, you can receive a medication that will significantly thin your blood out. And if there is a clot that's in your brain, it can potentially dissolve that clot. Or there are other treatment options that they can surgically do to help restore blood flow to the brain. So the faster you get evaluated, the more likely you have access to these types of therapies. Now, the brain can die quite fast. And so even if you get there on time and we're able to get you that clot busting drug, TPA or TNK, then we have now then the recovery from the stroke, right? And so there are a lot of advancements as well that can occur. I always tell my patients, though, the recovery from stroke takes time. But the more that you rehab, the more that you do after your stroke, the better you are to recover. Our brain is what we call has plasticity. So it has the ability to sprout new nerve cells, to reroute nerve cells that are there to help take over the function. But our brain doesn't know to do that unless we are rehabbing and we are doing the exercises, going to the therapy, so that we can tell our brain that we need this function. I need to move my arm. And so the more consistent you are, the more persistent you are with doing your rehab, whatever it's been tailored for you, the better you are to do it. But don't get discouraged too soon, because the recovery from stroke can take months and sometimes up to a year.
It's like running a marathon. You can't run out there. You can't just go out there and say, I'm going to run this 5K. You have to train. You have to exercise. You have to put in the effort to train your body to be able to complete that marathon. The same thing for the brain and the heart as well. You have to go out there and do the right things to train them how to respond to your needs. And Dr. Green, you can enlighten us on anything as far as it refers to the whatever you want to. Enlighten us on what you want to say.
Oh, well, the one thing I would like to focus on is prevention. And we did a lot of that. How not to get the stroke. And the one thing I would want to get into the conversation for the audience out there is that familiar term called atrial fibrillation, that abnormal heart rhythm that can lead to little clots in the heart that can cause you to get a stroke. And the reason why that is important in my own mind's eye is because it's preventable. So making sure that you keep your office visits with your primary care physician, making sure that you follow up with your cardiologist, whoever that happens to be. And if indeed you feel your heart being irregular, the beats are fluttering, terms that we use, palpitations would be another word. But if you feel that there is some irregularity in your heart and you have high blood pressure and you have what is, the usual things, diabetes and hyperlipidemia, that's high cholesterols, that lurking in the background as another silent problem with hypertension itself, is that abnormal rhythm that we call atrial fibrillation that can lead to small little clots that can get up to the brain. So that is a very important feature that I would want to get out to the audience out there. And then, of course, it comes back to being able to prevent that. And one of the ways to prevent it, as was described by Dr. Sanders, is the blood thinners. But unfortunately, this is blood thinners that you'll probably have to take for the rest of your life. And maybe we can start talking about that as well.
On that note, speaking of which, Dr. Green, is it a good idea for people to use a low dose aspirin on a regular basis? Or does that depend?
I knew it was coming.
I know it was coming. Aspirin, when I was been around for a little while, and when I came out back in the 80s, the aspirin a day and everybody should be on aspirin. And then we had to fight, what do we do with it? Do we take a baby aspirin? Do we take a full aspirin? Do we just lick the aspirin every morning? We weren't sure. Now, aspirin has come and has made a lot of a full 365 degree circle. Currently, the usual bodies, the ABIM, AHA, cardiovascular groups, everybody is coming out with some documentation of what to do about aspirin. The safe thing is if you're less than 75 years old and you do not have a problem taking aspirin, i.e., upset stomach or any bleeding conditions or easy bruising of the skin, I would say to all my hypertensive patients, particularly the ones with diabetes, that they probably should take an aspirin, enteric coated baby aspirin every day. And I would leave it right there. Above 75, it is felt that the downside does not happen to offset the risk. But a very nice quote that I heard recently is not mine, but I'll share it with the audience. Is that when you take that aspirin, you can get it to work actually better if you take it on a 3-mile walk before you take it.
Huh?
That's
It
not
works
mine.
for me. It works for me.
So back to exercise, back to being physical, back to not being sedentary is the way to go.
It doesn't matter the time of day that you take it. Someone asked
No,
me that
No,
question.
any time of the day, once is the same time of the day.
Dr. Sanders?
So the evidence suggests that for primary stroke prevention, an aspirin is not likely to lower your risk for having a stroke. What we've all been stressing, the risk factor modification is really what's going to give you the bang for your buck. And as Dr. Green mentioned, we had to, when they looked at the recommendations, it had to balance it between the risk. So nothing is without risk, including aspirin, and the risk for bleeding, particularly if you're at risk for falling and you were to hit your head, even it can cause extra bleeding in the brain. And so for primary stroke risk factor or primary stroke prevention, aspirin is not felt to play a huge role. But it is important for secondary stroke prevention. So once you've been identified to have a risk for a stroke, whether it's blockages in your brain, then aspirin, I think, is very important, and the benefits outweigh the risk at that point. But before then, maybe not so much.
Right.
Yeah, we had I have to say this, when you were talking earlier about the social determinants of health and access to healthy foods, I've been working with a group, the Black Church Food Security Network, really encouraging people to start their own garden, be it small or, in the yard. So in pots and or even in their backyard, but also in your community, right? If I go grow greens, you grow tomatoes, Dr. Kane grow, you know what I mean? So we don't have to grow a whole spread, but we each grow something and then we bring our bounty together. And that's how you make, it plentiful. And also I have to mention our former guest, Linda Brown, our friendly registered dietitian, when I asked her about reading labels, can you talk about reading labels? She said, you don't have to read labels on the food that you need to eat. And I'm like, well, yeah, that makes sense, right? When you think
They
about,
don't have labels.
they don't have labels, right? Yeah, that's how she said it. She said the foods we're supposed to eat don't have labels.
Don't
And
have
that's
labels.
really, really push the importance of eating more vegetables and fruits. But that's another conversation on how we prepare them. By the way, doctors, I remember telling someone, intellectually as a health educator, I know what to do. However, when I go to the grocery store or when I began to prepare my food, my good old Southern roots kick in terms of food preparation and fruit selection, oxtail, Dr. Green, right? So I'm just saying that, unfortunately, that happens. So now someone has a stroke. How do family members support their loved ones who've had a stroke? And food is obviously food preparation. They can't go back to the way serving the foods that they were having. What are some other things that people should know and do to support their loved one who've had a stroke?
So we talked a lot about the physical impact of stroke, right? But there's also the emotional impact of stroke. So stroke survivors can have other mood disorders that can occur with that. They can develop depression. They can develop lack of motivation because of frustration with where their physical levels are, and they lose some of their independence. So as family members, you can be there to be that encourager, to say, hey, you can get through this. We can work to improve it. Be the workout buddy, or be the physical therapist on the days when they don't go to therapy. Let's say, hey, let's do some of those exercises that the therapist told you to do. And then there's the economic impact of stroke. And so there are the bills that occur. There's maybe the loss of employment, or not being able to return back to work, depending on the level of severity of their symptoms. So the family is there to provide some of that financial support, and just really caring for that patient all the way around as their needs felt, physical, emotional, and financial or economic.
Be very nice if your people pay attention to the financial support part before the stroke. Mom needs a blood pressure medicine, or dad needs his diabetes medicine, or whatever it may be, and to also help mom and dad monitor what's going on with them before the stroke. It may seem like you don't have a lot of time to be running by there looking after mom to do this, but you're going to have a lot less time if mom had a stroke. And you got to either go to the nursing home, or she got to stay with you 24/7. Mom and dad, I shouldn't sound like, but they got to stay with you 24/7, and so on and so on. So the consequences of having a stroke is not just with the individual, but it's with the family, especially the family that cares. Okay.
Yeah.
The one thing I want to mention and bring up, and you guys can discuss, is vascular inflammation, because you're going to see it in both of these entities, whether or not it's cardiovascular disease or cerebral vascular disease. You see vascular inflammation, in which that just means to our layman in the audience, start talking about inflamed blood vessels that causes more cholesterol deposit, yada, 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 yada. Anything that they can do to help, and we probably talked about a lot of it already, anything they can do to help modify that. Because one of the other things that hadn't been said, we talked about stroke, but damage to the brain can be limited, if you want to call it that, to a vascular dementia. We didn't even talk about dementia, which, most people think about Alzheimer's when they think about dementia. But you got damage to the brain and to the brain blood vessels, and you start wondering, mom forgot this or forgot that. Is this early dementia, or what are we looking at before stroke? Dr. Sanders, I think that might fall somewhat into your purview.
Yeah. So, but your first question was about, vascular inflammation. And I think that is really loops back around to what we've been talking about in the vascular risk factors, particularly, with smoking, and managing your diabetes. And so I think that and blood pressure, that kind of lessens the inflammation that can occur within the blood vessels for that. But you're right. It's extremely important. I think vascular dementia is the second cause of dementia in patients. And so it's the repeated hits to the brain, some that you feel you've had a stroke symptoms, but those can also occur. Also, non-symptomatic things can occur as well, and you can develop vascular changes in your brain, which disrupts how it communicates, which is necessary for memory. And so if we can prevent some of the vascular changes, we can prevent dementia in a lot of our patients. It's pathologically different than Alzheimer's, and so we have to sort that out if the problem does exist. But yes, it's not only just treating the here and now, but the 10 or 15 years down the road, definitely.
And we also have to think about those parts of the brain that maybe, so we've been talking about, just now, we talked about vascular dementia, we talk about the part of the brain for memory. We don't talk about the other part. We didn't say anything about the brain that will help you, the part of the brainstem, or others that you can also get vascular issues with and cause you difficulty with breathing, with whatever it is that occurs within the brainstem.
Oh, definitely. The brain controls everything. That's why I went into neurology, because I wanted to be in control of everything. And so things from our swallowing, our heart rates, our breathing, our ability to move, everything is all in the brain, and every location, our vision. I'm going to throw that one out there too.
Yep.
So everything that we can control can be affected by stroke. And that's, again, not just the blockages and the blood vessel inflammation, but that really explosive hemorrhagic stroke or bleeding type of stroke that can lead to some severe disability.
Yep.
So, people are so accustomed to going online, checking out information, or if we saw a good movie or read a good book, where are some places, other than, of course, your physician, where are some reputable places that people can read to learn more about? We talked about a whole lot tonight. Are there any resources just for laypersons that they can go and learn more about strokes, stroke prevention, and heart attacks, and all that other good stuff? Doctors, anybody know of any place?
I would just say one word, actually. Google it.
2 words.
2 words. Not if you bundle it. Anyway, that's a good. So the prevention. The vasculitis, the inflammation of the blood vessels, all of that comes down to controlling your blood pressure, controlling your blood sugar, looking after your hemoglobin A1C, something that your internal medicine doctors will mention to you. I know we don't pay as much attention to it as we really should. But in terms of prevention, one of the things I think we should be focusing on and trying to do is to decrease the level or the amount of sugars that we put into our bodies. I always tell my patients, the ones who pick on me the most, and who would waste time listening to me, is if you want to live to be as old as Methuselah, there are 2 things that you should do: get rid of sugar and get rid of salt. Now, both of those 2 things.
Not the deadbeat spouse. I'm sorry, I digress.
Both of those things are very difficult to do, but the point is made. And what I'm aiming to do here, what I'm angling to do, is to pick on one of the entities out there that troubles me the most, and it is called high fructose corn syrup. And it gets back to the dietitian that and the concept of labels. Yeah. And then it gets back to the concept of what is really a sugar, right? And recognizing that the sugar that you're going to get from vegetables and fruits is not the same kind of sugar you're going to get from a donut, that you're going to get from white flour substances. So again, diet is so very important. And high fructose corn syrup, we should try to make every effort to remove it from our diet. Yeah. And I would submit to the audience out there is that everyone should try to go on a holiday from high fructose corn syrup. Literally go on a holiday. And I've done this myself, so I can speak to this personally. Wipe out high fructose corn syrup by looking at the labels. Try and get rid of the sweet tea, the sweeteners, and everything else for, I would say, about a month, 4 to 6 weeks. And you will actually feel better. There will be some increment of betterness that you will feel.
And weight loss.
And then I want you to do something after that. When you start to think that you're really feeling better when you get that level of sugar out of your system, start it back again. And the first thing that you will notice to a patient is that you will not be able to get around the corner that I call 2, 3, or 4 o'clock in the afternoon. You can feel that tiredness come back again. If you can get yourself to the point where I can give you a substance and you can, a liquid, a fluid, and you can say to me, this has in high fructose corn syrup, you are in actually a very good place, because your body would have recognized that high fructose corn syrup as a sweetener is really not good for you. You have the ability to literally taste it. And I submit to you that if you can get high fructose corn syrup out of your diet, you would have done yourself an enormous favor. The problem is it is so ubiquitous. It is everywhere in
Everywhere.
everything.
Chief,
And I submit, I contend that high fructose corn syrup is one of the greatest sins that the industry has inflicted upon human beings. And if
Is it also in sugar-free products, Dr. Green? You know, because a lot of things are sugar-free.
No, you got to be very careful when you say sugar-free, because sugars come in all sorts of forms. There's stevia, there's aspartame, artificial sweeteners. I am not using sugar, but I'm sweetening with Crystal Light. It gets very complex, and I don't want to get into I don't want to disrespect the dietitian, but I spend a lot of my time, even as an electrophysiologist, talking to my patients about what they eat. You are what you eat, and it is an effort. But high fructose corn syrup is one of my favorite things to talk about. And then I get into the starches, the breads. I mean, everybody loves bread. It is so infectious. And you don't have to wipe it out completely, but we all know what we're talking about, the starches. And I feel that I can, since you pick on me and my oxtails, and that's a private joke, by the way. I starches. So when my diabetic hypertensive patients start to get in trouble, I ask them to pay attention to their salt intake, and I ask them to pay attention to their carbohydrate intake. Just that simple move. Not understanding very clearly that when you go to the supermarket and you shop, and I do, it is harder to find good vegetables that are fresh. The concept that you mentioned of a village looking after itself, everybody that's happening to choose to grow a particular root or onion and share it with the community. That is actually a very brilliant thing to do. So that when you have your after Sunday church functions, that would be a good time to literally
bring your bounty together and share.
Yeah, that's exactly.
And even have the church participate in it. But
after worship service, everybody just bring a fruit and vegetable, and then you just share. I mean, you barter
it off if you want to.
Yeah. Well, we're beyond the hour.
Dr. Sanders might have had one thing to add to that.
I know, Dr. Kane. Hold on a second. I was getting there. We're rounding out the end of the show. I wanted to mention to our guests to say, do you have a few more minutes before we close out? Otherwise, we need to wrap up because we are beyond our hour. We like to respect your time.
I only have one thing to say, and you asked where can they go and find good information. Google is out there, but there's a lot on Google. If you think about stroke, just add a .org to it, stroke.org, and it can talk about prevention, treatment, and recovery.
That's a good point. And heart.org as well. So thank you. American Heart Association, American Stroke Association, Centers for Disease Control, the National Institute of Health, just to name a few. So again, we're at the end of the show, and Dr. Jones is right. We need to this is a two-part segment, right? A whole lot we didn't cover tonight. Dr. Kane always says that, by the way, Dr. Sanders.
We warn you, but we warn you.
I'll be back.
I'll just go ahead and put it out there. Yeah, there is a lot. And for those persons who have loved ones who are suffering, it's a very complex topic. And for people who Dr. Green talk about, his patients that come in, it's very complex when you're trying to change your whole life. 60, 70 years, you've been eating a certain way, and now you're told not to. Right. So it is very difficult. But we are at the end of the show, and we like to give our guests an opportunity to share their final thoughts or give our viewers a takeaway from tonight's topic. So, Dr. Green, I'll start with you as our former guest, and not because of anything else other than because you're our former guest. But what are your final thoughts regarding tonight's topic?
Final take home thought. When you go to visit your doctor to speak about your hypertension, your blood pressure, your atrial fibrillation, your diabetes, never go alone. Take a companion, a spouse, or somebody else with you. It is so very important.
Yeah.
At some point in time, I force my patients to bring spouses and significant others because the majority of what is said, if you were there by yourself, goes right over your head.
Yeah.
It happened even to me myself, visited with my primary care physician, and I
Mhm.
realized how powerful a thing it is. People don't like to feel that they're in trouble, and they are. And it's not negativity, but the one thing I would like to take away from tonight is that when you visit your physician, have a spouse in the room with you. You get a lot more will come out of that encounter.
Thank you, Dr. Green, from a single person who doesn't have a spouse.
Take him out.
We'll somebody in. But Dr. Sanders, what are your final thoughts regarding tonight's topic?
I think that we talked a lot about prevention, and that may look different for different people, and so I think it's working on those lifestyle modifications, decreasing your risk factors by not smoking, managing your weight, controlling your high blood pressure and diabetes, which are all things that can affect anyone of any age. And I see that there's a question of why does it happen to younger people? It's because all of those things, obesity, smoking, diabetes, high blood pressure, can occur at any age. So of course, anyone can have a stroke. So really the take-home message is prevention.
Thank you, Dr. Sanders. Dr. Kane, what are your final thoughts regarding tonight's topic?
Well, I know we're used to going back on what Dr. Sanders just said. I know we're used to hearing older folks having strokes.
Yeah.
And so when the questionnaire or the listener asks about young folks, it's because I think young folks do have strokes, have had it for a while, but I think with today's social media and all the other quick communications that we have, we hear about it more. Okay. And the thing that, I try to remember, and when we try to pose our podcast, is that we have physicians or clinicians and patients listening. And we really try to cater it a lot to what the patients are for their education. But technically speaking, it still winds up being an education for physicians as well, in terms of how to help take care of their patients, what their patients' concerns are. I do definitely think we're going to need a part two of this conversation.
Yeah.
Dr. Jones mentioned about having some pictures. I remember as we were talking, I thought about this little blood vessel model I got in the office. I'm going like, boy, this would be perfect. I could show this at this time. So I think that we need to come back, take part two of this, take another look at it, and depending on what I guess free times are, we can do it next week, but it depends on you guys' schedule. And so we need to look at that. The other thing is just quickly about Google. Yeah, we're not asking you to diagnose with Google. We just asking you to start trying to look for places to obtain information with Google. And the final thing is, this is not one of these, but one of these like, oh, Jesus. Dr. Green mentioned what his specialty is and what he likes doing. So my specialty is primary care, but I'm a specialist in cardiology, neurology, gynecology. I can go on and on. So I want patients, you start with your primary care physicians because they will know who they can refer you to that can give you the best treatment. One of my guests said they're happy that we have people like yourselves on this podcast. And and I know some bad neurologists. I know some bad cardiologists that I probably wouldn't send my dog to. However, I made sure I operate by the motto, and I think most of the primary care physicians that look like me of a certain persuasion recognize that Black physicians do tend to do better in terms of outcomes. Most Black physicians do better in terms of outcome with Black patients because they can communicate better. So see your primary care doc, see if they can turn you on to some people that will help you instead of ignoring your complaints of and what symptoms you have, whether it's palpitations, whether it's numbness, tingling around the mouth, whether it's a drooped eyelid and they want to write it off to something else. Listen, you know, if that guy, a lady is trying to connect with you and thinks about you like they do with their family, they're going to get you the best physician. And they just got to remember, do whatever it would that you would do for your mama, sister, brother, son, daughter, period.
Thank you, Dr. Kane. Remember that stroke prevention is a journey that involves making informed lifestyle choices and staying proactive about your health. Some key takeaways are, of course, maintaining a healthy diet, eating a balanced diet rich in fruits, vegetables, whole grains, and lean proteins. And as Dr. Green said, limit salt, sugar, and unhealthy fats. Regular exercise, aim for at least 30 minutes of moderate exercise most days of the week. The whole 3 days a week went out the window years ago. It's most days of the week. Maintain a healthy weight. We all know what that means. Control your blood pressure. Avoid smoking. Limit alcohol. Manage chronic conditions like diabetes, high cholesterol, and heart disease. Make sure they're under control and that you're going to your primary care doctor on a regular basis. Stay informed. Tune in every week on Pause for the Truth as we bring experts on the podcast to help you with manage your chronic conditions. By incorporating these practices into your daily life, you can significantly reduce your risk of stroke and enhance your overall health. Thank you for tuning in. Take care, and we'll see you next week on Pause for the Truth. Thank you,
Hang
Doctor.
on, you guys. Okay.
And there we have it, another episode of the Pause for the Truth podcast in the proverbial books. Our heartfelt thanks go out to every one of you who took the time to tune in. Mark your calendars. We're here every Tuesday at 6:30 Eastern Standard Time. Feel free to join our community on Facebook, Twitter, and LinkedIn. But the golden ticket? Subscribing to our YouTube channel. That's your passport to all our latest episodes and exclusive content. A special mention to the wizard behind the curtain, Tyrone Jackson from Call Tyrone IT Services. His technical prowess and unwavering dedication are the backbone of this podcast. Next week, we'll be back with more. Until then, tell your friends, tell your family about our show. Your support is invaluable.